brief introduction. Um, so, Hi class. Thanks so much for returning this week. We're really excited. We have an extremely exciting lecture from Dr. Khatri on neurological manifestations of COVID-19. So, as you know from your pre-assignment, while it's known that COVID-19 can disrupt multiple body systems, as we've learned throughout the course, the effects of the virus and the body's response to COVID-19 infection on the brain, spinal cord, nerves, and muscle can be particularly devastating. Debilitating headaches, fatigue, cognitive difficulties, stroke, pain, and sleep disorders can plague patients who have suffered from COVID-19 even after the virus is cleared. This week, we will be led in a discussion on how a virus we cannot even see can disrupt the very way our brains work by Dr. Pooja Khatri, a vascular neurologist and scientific authority on the relationship between COVID-19 and strokes. Dr. Khatri is the director of the Acute Stroke Program for the University of Cincinnati College of Medicine Stroke Team and a professor of neurology at the UC College of Medicine. Dr. Khatri received her Bachelor of Science with honors in biological sciences from Stanford University in 1995 and her MD with honors from the University of Illinois College of Medicine in 2000. After neurology training at the University of Pennsylvania, Dr. Khatri came to UC in 2004 to complete a vascular neurology fellowship through the NIH Specialized Program of Translational Research in Acute Stroke. She joined the UC faculty in 2005, was awarded an NIH Career Development Award K23 in 2006, and received the American Heart Association Robert G. Seekert Young Investigator Award in 2008. She completed a master's degree in clinical epidemiology from Harvard University School of Public Health in 2011. In addition to providing neurological and emergency stroke care to patients at the UC Medical Center and more than 15 area hospitals, Dr. Khatri participates in the leadership of several international multi-center clinical trials and leads UC's National Institute of Health Next Network clinical site for pilot trials of neurosciences. She has been a standing member of the FDA Peripheral and Central Nervous System Drug Advisory Panel and has authored numerous manuscripts, books, and clinical guidelines. She was one of 3 Americans elected to the board of World Stroke Organization in 2016. Since the outbreak of the COVID-19 pandemic over 1 year ago, Dr. Khatri has published 5 articles specifically examining the effects of COVID-19 on emergent stroke care. Dr. Khatri, thank you so much for leading this discussion on the neurological manifestations of COVID-19.
Thank you, Scotty, and thanks for that kind introduction. Welcome, everybody. This is an interesting topic with probably more questions than answers, and I'm happy to chat with all of you. I just want to say right off the bat that I'm more than happy to take questions as we go along. I'm happy to clarify. I want to make sure that your questions are being answered and that I'm explaining things clearly enough. So don't hesitate to make this a conversation as we go along. I think Scotty's going to watch the chat box for me because I can't seem to see it when I'm in presentation mode. But that should work out just fine. I guess just to start and let you know that as far as my financial disclosures, they're all related to research efforts and trials that I'm working on. And the one that's particularly relevant is Active 4A, and actually I should have added Active 4C, which are 2 NIH-funded platform studies, which are multiple trials in one, looking at the role of antithrombotics, blood thinners, in the setting of COVID. So our group, which is a National Coordinating Center for Stroke Trials, was actually brought in to help facilitate this really important set of questions during this public health emergency. So I'm involved in helping implement that as well. It is crazy to think about this particle, which is hugely enlarged hair, that is 1/10,000th of a millimeter and is only 15 genes compared to the 30,000 genes in humans, and how it has thrown off our whole planet Earth with this pandemic. So as far as COVID goes with the brain, I think it's helpful to think about it in the big picture first. And the most common symptoms that people have with COVID are going to be myalgias or muscle aches. They're going to, and that's part of just the neuromuscular, system. They'll have headaches. They'll have something called encephalopathy, and they'll have dizziness. And just to give you a sense, encephalopathy is basically alteration in an ability to think that sort of waxes and wanes with sort of sleepiness or unable to think clearly. And frankly, it's what the lay press has often been calling a brain fog. Encephalopathy can be as mild as just a little bit of cognitive impairment, or I should say a brain fog, or what they've referred to in the lay press as a brain fog can be as limited as a mild cognitive impairment, or as severe as the patient who is, difficult to arouse in an intensive care unit, who isn't thinking clearly and sort of comes and goes with their consciousness. So those are the things that we see most often: muscle aches, headache, encephalopathy, dizziness, as neurologists and taking care of COVID patients. The other, a little bit less common, but very specific finding that you've all heard about at this point is change in taste and change in smell. And then much less common are things like stroke, movement disorders, and other focal impairments, and I'll touch on those as well. So as far as how the COVID virus, how COVID-19 causes these neurological manifestations, it's a pretty messy literature, and it's a pretty messy story right now as we continue to learn. But what we know is there's two roles. There's the systemic response to the infection itself. Anytime anyone is really sick, it can mess with the brain, or the related tracts in the spinal cord, or the nerves or the muscles. And then also there's the fact that the virus can sometimes actually directly invade the brain. So as far as systemic responses to infection, one of the things that I know you all had lectures about are the idea that COVID can affect the lungs and affect our ability to breathe, to maintain the structure that allows for that oxygen transfer. So when there's a low state of oxygen in the blood, that's called hypoxemia. And certainly when people are hypoxic, that can lead to brain injury, that can lead to encephalopathy. That's one of the earliest symptoms of a hypoxemia. If a patient is getting sleepy, we check their oxygenation. It's one of the first things we would do. And then even after that oxygenation injury, sometimes that can set off sort of a cascade molecularly that can lead to changes that we see in the brain, which we call post-hypoxic brain injury. And then the other thing is when patients are in the intensive care unit and they're that sick that, say, we've intubated them and we're basically breathing for them on these machines, and we're giving them IV fluids, and we're sometimes even helping them with, their kidney function. This can cause metabolic derangements. And anytime you have metabolic derangements, whether it's in sodium, whether it's in kidney function or other areas, that again can put patient in a state called encephalopathy. We as neurologists will often get consulted throughout the hospital with the sickest patients. And one of the most common reasons that we'll find that the patient is not being themselves, seems like they're in this deep brain fog, is that they are having a toxic or metabolic encephalopathy. So that's what we refer to that as. The other thing about COVID is that we know it puts people in a pro-inflammatory state, and we're still learning more and more about that. It seems to be a very powerful inflammatory state in some people. We don't know why some people have it so much more powerfully than others. Age has a little bit to do with it, clearly, but that can cause, gross thrombotic events where you have a blockage, just a clot that blocks blood flow to any organ. Or it can be microvascular injury. In other words, those little tiny vessels in the organs that are basically perfusing the organ at the capillaries. Or it can cause an endotheliopathy, such that basically the virus, and there's some debate about whether it's actually directly infecting the vessel walls of blood vessels, or whether it's setting off an inflammatory cascade that upsets the blood vessels. But either way, all of those things can lead to clotting type disorders in this pro-inflammatory state. So a term that we've been hearing a lot now, way more than we've ever talked about until COVID came, is thromboinflammation, and I've heard some people call it immunothrombosis. And it's basically this inflammatory state from infection that then sets off clotting, whether it's macro or micro. This is a picture here, and I'll show you, I actually zoom in on it to show you an example of how this could play out. This is a 45-year-old man. This was published from actually the NYU group, one of the early publications about COVID and its neurological manifestations. The patient was ventilated, and in other words, intubated, and for 28 days because they couldn't maintain their oxygenation on their own, and died after 47 days of hospitalization. And what you can see here on their MRI is you see these hazy whiteness. That's white matter signal abnormality. It can be pretty nonspecific, but it tells you basically that that there's been some kind of injury. They're also in this kind of MRI modality. You see these little black dots here. Those are microbleeds. That's another thing that we see in the setting of COVID sometimes. And then we see that these white matter changes that I pointed to here, this hazy area, when they light up like this on a sequence called DWI and look dark like this on a sequence called ADC, that's specifically cytotoxic edema, diffuse cytotoxic edema. In other words, there are neurons that are dying, and there's a breakdown in the sodium potassium ATP pump, such that we're seeing cytotoxic edema. So basically, like I said, that systemic response to infection can be related to things like low oxygen, metabolic derangements, this pro-inflammatory state. And then anytime, and we know this from neurology with other infectious causes, that infections can sometimes set off autoimmune disorders where oftentimes there's some molecular mimicry or maybe something more complicated such that the immune system actually attacks the nervous system. The most common one, it's a rare disease, but yet, we as neurologists know about it and treat it regularly because, the patients come to us from all over this part of the country, even the tri-state area, is Guillain-Barré syndrome, where basically and we often see that after someone's had the flu. The most classic one is actually after a Campylobacter diarrheal illness. There's been some great, studies showing that there's actually, it's basically the myelin, that the Campylobacter bacteria actually has some molecular similarities to the myelin that covers on our peripheral nerves. And so what happens then is these patients develop peripheral demyelination acutely, and they develop a paralysis, which is called Guillain-Barré syndrome. We have been seeing that with COVID. Again, rare but real, and just like we do with the flu and other infectious causes. And then we do know that COVID does directly enter the brain. We've seen, it's been reported in autopsies in brain specimens. And like I said, it's controversial about whether it actually directly infects the vessel wall. So I'll pause there to see if you have any questions, Scotty, from the group. Whoops, I think you're on mute.
Sorry. I'm not seeing any questions yet, but I'm
Okay.
sure as we go along, there will be some coming up.
Okay, sure, no problem. So I'll then dive in and chat about a few of these different neurologic manifestations to talk about what we know and what we don't know. So as far as smell and taste, there isn't like there isn't a great series out there that's completely generalizable, but based on case series, we think it could be up to even 80% of patients that can have smell and taste issues. It's rarely isolated as the only symptom. And at this point, there are a couple possible mechanisms. One is, whoops, sorry about that, is direct invasion into the brain through the olfactory epithelium, and then basically the neural mucosal interface. There's a picture here of an MRI, and what you can see here is, see how right here, this is actually gives you a little illustration. This is a patient with anosmia. And these are the bulbs of the neurons, the olfactory bulbs that go into your nose and project then into the brain being up here. So this is the bulb, this is the brain. And you can see now, so that's just, a color illustration. That pink area is the bulb. And if you look right here, what you can see is how it looks kind of whitish, whereas here the bulb looks dark. Whenever we see hyperintensity like that, that's basically an abnormal signal change. And so it's been reported transiently that people's olfactory bulbs will light up and then go back to normal. So kind of suggesting that yes, there is something going on there that is causing this inflammatory change. And then basically there have been biopsy results showing that there can be COVID in going across that pathway. But then the other reason people can have trouble smelling can be related to just inflammation in the nasal passage. And I think you've had a lecture that probably went into that in detail, but I thought I'd mention it just to round things out. Um, and to the degree that, and our ENT colleagues might have more experiential knowledge, but basically the very limited publication data suggests that many people do recover, maybe on average in 1 month, but again, there's still a lot more kind of big scale data that needs to be collected to get a full grip on this. So let's talk about encephalopathy. This is patients who can be either agitated and not have cognitive impairment. They can wax and wane with that. They can be sleepy. They can be difficult to arouse. And that's at least half of patients with COVID who get admitted to intensive care units for the many multifactorial reasons that I mentioned to you. The patients that tend to become encephalopathic are sort of exactly who you'd expect. They tend to be older. They tend to have faster disease progression. We've generally known that males have been a little bit more affected than females with this. And then they have other risk factors that are just suggest that they have more comorbidities. They're a little bit sicker, whether it's neurologic disorders, cancer, cerebrovascular disease like prior strokes, chronic kidney disease, diabetes, dyslipidemia, heart failure, hypertension, or smoking. It's less common for patients to present with just that kind of confusional state as their only symptom of COVID. But again, it comes down to having other comorbidities that make them less well. And at this point, it's really unclear whether you can have sort of this prolonged confusional state without having had decreased oxygenation. So we have more work to do to sort this out in more detail. As far as MRI findings, approximately half of patients that show encephalopathy will have some sort of abnormality, and it could be an actual stroke. It could be these white matter changes I was telling you about before with associated hemorrhages. Sometimes you can see basically on the surface of the brain that there's basically enhancement, which suggests that there's infection of the meninges that surround the brain. Sometimes you can see areas light up within the brain with contrast that suggests that there is a breakdown of the blood-brain barrier and infection within specific areas of the brain. A particularly notable thing is that we sometimes see lesions in the corpus callosum, which in the splenium of the corpus callosum, that's not something we see with a lot of diseases. So it's sort of notable that we see that with COVID. And it's thought that, steroids might theoretically help, but whether they actually do for the situation is uncertain. I will say as neurologists, sometimes when we have a patient who has some sort of nonspecific inflammatory condition and we have done all the workup we can under the sun, including a brain biopsy, sometimes we will try a course of steroids because these patients can develop sort of an autoimmune condition where it sort of spirals on itself and they develop and this sort of breaks the cycle of that immune response. It's one of those things we don't like to do because it's sort of a shot in the dark. There are case series published with severe encephalopathy patients to improve when you give them steroids or plasma exchange, which is another way to clean out the immune system. But at the end of the day, it's hard to know because as you've probably been learning, it's really, people like to publish something that, in a small series that they think works. And they might have just gotten lucky, and there might be another series that would have showed it didn't work. And until you have, good systematic studies, you can end up with publication biases that make you think that your treatment worked. Ideally, obviously, you're going to do a randomized trial. So anyways, bottom line is when you see encephalopathy, though, it's a risk factor for poor outcome. So I'm going to switch gears to stroke now. You all might have seen headlines like this from the New York Times. This was actually, I think, Mount Sinai actually released several cases about this, and even put a letter in the New England Journal of Medicine suggesting that they were seeing a lot of younger patients with really big strokes, and they wondered if it had to do with COVID. Many of them were COVID positive. And so we saw that in the New York Times and USA Today. And now that the dust has settled, we've come to the conclusion that, yeah, there is definitely a little bit of an increased risk of stroke with COVID compared to, say, the flu, but it's not this second epidemic that we were worried about. We were really nervous, like, how is this going to work if all these patients are going to develop strokes? Is this really what's going to come? And, last March we were completely in the dark, but now we've had a chance to let the dust settle. And what we know is that ischemic strokes, which are basically strokes where you have a blockage, you have a clot that blocks blood flow to the brain and then leads to an area of the brain to die from lack of blood flow, that occurs in maybe 0.4 to 2.7% of patients, whereas a blood vessel rupturing and then bleeding, like this picture here on this CAT scan, occurs less frequently, about 0.2 to 0.9%, which sort of goes along with just generally what we see with stroke. Usually about 85% of strokes are ischemic in the general population and 15% are hemorrhagic. So that with more severe COVID, the rates of stroke are higher. And it usually occurs about 1 to 3 weeks after the COVID symptoms have occurred. And there was a nice study actually out of Cornell where they retrospectively looked at 2 academic hospitals. I think it was Columbia and Cornell. And they combined their data and showed that basically, with influenza, you saw about 1.6% of patients developing strokes. Or sorry, with COVID, you see about 1.6% of patients in their cohort developing stroke compared to 0.2% in previous time periods with influenza. So, so again, it's not, this second epidemic, but it is certainly an increased risk, and it's probably due to the effects that we are learning that COVID has on causing hypercoagulability and inflammation. I think a really important thing to keep in mind is that for me as a stroke neurologist, when I'm seeing these patients, ultimately they look like typical stroke patients for me. They're not necessarily the young patient. When I do have a young patient, I'm always looking for unusual causes, and COVID is one of many of them. But typically the patient who's going to have stroke in the setting of COVID is that same patient who was going to have a stroke outside of the setting of COVID in terms of being obese, smoking, diabetic, high cholesterol, the hypertension. Those are the traditional risk factors for stroke. And then this added non-specific risk with the infection of COVID. The other thing I'll mention is that whenever you have a situation where oxygenation is low, blood pressure can get low, and if you have vessels that were already narrowed with the wear and tear of age due to atherosclerosis, it can be a setup for stroke sort of in these watershed areas because of this low perfusion. So in other words, what I'm saying is patients who are really sick can develop strokes. And so when COVID makes you really sick, you can see strokes in that setting. Now, COVID can also cause a myocarditis and make the heart weaker, or you can be so sick because of the general inflammatory state and the lack of oxygenation that your heart isn't pumping correctly. And either of those settings, when the heart isn't just sort of pumping robustly, you can end up with blood that's just sort of swirling in the heart because the heart isn't pumping strongly, and that can lead to clot formation that can go to the brain. and again, caused stroke. So that's why cardioembolism is listed there as a potential cause. And then the other thing that can happen is when patients are really sick, even near comatose, it can be really hard to tell if they've had a stroke. And a lot of times we put these patients on blood thinners, so we may inadvertently ourselves contribute to them having a hemorrhagic conversion of an ischemic stroke. There's also patients you might have heard of, I think you've talked about in your previous lectures, who might get ECMO, which is a way to basically oxygenate the blood through without using the lungs. Well, one of the risk factors of ECMO is, or one of the complications of ECMO is indeed hemorrhagic stroke or intracerebral hemorrhage. So that happens as part of the treatment. And then finally, I'm going to spend a slide or two telling you about the hypercoagulable states or thromboinflammation associated with COVID-19. Basically, from what we know at this point, COVID-19 seems to lead to platelet activation and lead to arterial clots. It can through a number of routes, including platelet activation. It can cause localized intravascular coagulation, which can be related to basically white blood cells, being activated, the blood being sort of thicker that way. Endothelial damage, in other words, those vessels that we were talking about, the linings of those little vessels. And so you can get clots that are just these tiny microthromboses. And then the veins that then drain these organs, we know that venous clots are have a distinct causes, and many of the factors related to venous thromboembolism are also activated by COVID. And so you end up in this situation where it's a setup for thrombus formation. So it's not surprising that patients who were already predisposed to stroke might be more likely to have a stroke in the setting of COVID. Now, it's really interesting. We were one of many groups throughout the country and actually the world who showed that as a stroke team, and actually I should back up and say, for people who don't know this, we're a little bit unusual. We're one of the few stroke teams in the country where we serve the entire region. So, we don't just serve UC Health for patients who show up in the emergency department with a stroke. We serve every hospital system basically in the region. It's about 21 hospitals total. So we get sort of a bird's eye view of our population, really, when we take stroke call. And we started to realize as a team that when they announced the closure of schools and restaurants right around that time, in fact, magically that week, our stroke calls dropped off dramatically. You can see here, these are the number of calls that we got per week on the order of, 120 to 140. And this yellow line basically shows you in 2020 that we dropped off to like the 80 range. So that was really, striking to us. So we, decided to look a little deeper. We looked like a year ago, because sometimes we do know stroke is seasonal. I already told you that flu can increase the risk of stroke. So we wondered, how does this compare to a year ago? Well, the blue line is 2019, and you can see it stayed pretty steady. That dotted line that you're seeing there is just the modeling that shows you roughly, where that blue line generally lands on average. When we looked at actually treating patients for stroke, now keeping in mind that we can only treat patients for stroke if they come in early enough to be treated for stroke, we noticed that our treatments had gone down too. So again, here's the yellow line. It was interesting because our treatment rates were going up a little bit, if anything. Then we know that this is generally true because we've had some new treatment options. So generally over time, we tend to treat more and more patients with whether it's with TPA, a clot dissolving agent, or with endovascular therapy where we're pulling the clot out. But basically, schools and restaurants closed, and suddenly we were treating less patients. This was a little less compelling, but it was actually statistically significant, and lots of other centers noted this. And in fact, there was a really nice international publication where they pulled together data from across the world, and it's a pretty consistent phenomenon. So at this point, we're not sure what that was about. There are a couple hypotheses there. One is that people with milder strokes were more likely to stay home because they were scared to go to emergency departments because there was COVID there, because they'd been told to avoid going out if they didn't have to. The other hypothesis is that we actually were set up to have less strokes in general because we were going out to restaurants less. And this is a slide from a colleague that presented at the International Stroke Conference. And, he threw out the idea that, he was strongly hypothesizing that there may have actually been a real reduction in stroke, that we were going to restaurants less, that we weren't seeing other people to get other infections that make our stroke risk go up. There was less air pollution. We were taking better care of ourselves. Maybe we were taking our meds more consistently. Maybe we weren't binge drinking, although there's evidence to the contrary too. And maybe we were getting time to exercise, or maybe we weren't. So there's a lot of questions there. And I think, to me personally, when I look at just how dramatic our drop off in calls was magically within a week, I can't help but think it's actually a chosen behavior. But the cool part is that we should be able to answer this question very soon because we actually have some of we have population-based epidemiology data in Cincinnati, and 2020 is actually one of the years that we were already collecting. So we're going to actually be able to say what was the denominator, not just those patients who showed up in the emergency department and called the stroke team, but what was the denominator from death certificates and outpatient visits and hospitalizations, and did that denominator really go down during this time period? So stay tuned for that answer. Scotty, you got a question for me?
Yeah, Dr. Khatri, Hannah was wondering, are there any theories as to why strokes have been associated in younger patients infected with COVID-19 as compared to older patients? Like why there was specific interest in that?
Like I said, it's hard to know how much of a fully real phenomenon it is. I suspect it's sort of partly real, but it's not as robust. Part of it is, it's sort of like, it's just what you happen to see and it's anecdotal and it jumped out. But part of it is probably there is a little, I mean, like I said, there's this little bit of an increase in stroke related to COVID. So my hypothesis, and time will tell, is that yes, we probably have more strokes where we didn't know the cause. They're cryptogenic. They occur in people who don't have other vascular risk factors. So we're seeing them a little more often. Probably not as dramatically as we felt like we were in the beginning. But again, it comes down to that idea that COVID is activating the inflammatory system to cause coagulation. So in other words, I would say it's not necessarily as big of a phenomenon as we feared, but there's a little bit of a contribution to this, if that makes sense.
Great, thank you.
Sure, thank you. I will say that as far as treating stroke, we basically do our usual stroke care. The biggest thing is we presume all stroke patients could be COVID positive until proven otherwise. We talk with them. If we can talk with them, that's great because then we can establish, their symptoms. But a lot of times we can't talk with our stroke patients because one of the common causes of symptoms of stroke is an abrupt inability to use language, aphasia, in other words. So we were quick. Our team was very quick to develop, an algorithm for how to handle these patients, knowing that sometimes they're going to be COVID positive, showing up emergently, and we're going to have to take care of them with the possibility that they have COVID without sort of having our stroke team, exposed to COVID in unsafe ways. So that's another way that our stroke team was able to make an impact in thinking about clinical care. So I mentioned the active trials, and I'll just touch on this to say that basically through Operation Warp Speed, there were a series of trials that were initiated that didn't go through the usual NIH mechanisms where you'd apply for a grant and maybe in a year you'd find out if you got the grant, and then you would get started because we didn't have a year to wait around. And so there was basically another mechanism through NIH that allowed us to be able to start early with the COVID trials. And, each active platform, one of them focused on vaccinations, another one focused on convalescent plasma. Active 4 was the one focused on preventing thromboembolic events, and specifically whether we should use antithrombotic medications, blood thinners in these patients even before they've had a stroke or a heart attack or a clot in their legs, and see if these patients will do better. And the thought was maybe it'll also help with their lung disease, because as you know, those microthromboses are part of what causes a patient to have respiratory failure. So these were set up as what are called platform trials. A classic trial would be, I want to see if I should do X or Y, and I randomize patients to X versus Y. But they're more sophisticated statistics that allow us to basically say, I want to look at X and Y, but I also want to look at X plus Z and Y plus A. And I'm going to adjust this as I learn more information and one becomes standard of care. And so without getting into the details, these platform trials have been an emerging concept, and they really shined this idea of a platform trial in the setting of COVID, because the active 4 trials have already given us some answers as they continue as the platform continues. The idea is that their patients are either enrolled when they're hospitalized, if they're in active 4A, or they're enrolled while they're outpatient if they don't ever get hospitalized in active 4B, or they're enrolled on discharge, and that's active 4C. And the idea is that the first sort of set of testing involved, should we put these patients on full dose anticoagulation and versus just give them just standard of care treatment. And what we've already learned, and there have been news releases about this, and the papers should be published soon. We learned that if a patient was in what's called the moderate state, in other words, they were in the regular part of the hospital, they weren't intubated, they were less sick, they were better off with anticoagulation, full anticoagulation up front. It was superior to doing just standard of care treatment, which is just like a very low dose of blood thinners to keep them from clotting. But if they were already in the ICU and that's when they were enrolled in the trial, they actually had no benefit from that full anticoagulation, and there was even some evidence of harm. And so intuitively that makes sense, because at the point that you're at the ICU, you've probably got a lot of clotting going on, and the cat's probably out of the bag. And once you have the clotting going on, you've got organs, whether it's the brain or elsewhere, that are frankly, to just put it very simply, they're leaky, they're dying, and they're more likely to bleed. And so then you throw blood thinners on that, and that's not necessarily a good thing. So we've already got some answers about what to do with our patients thanks to these trials. And now what the platforms are doing is asking the next question, which is, okay, so should I also put them on something that's sort of like a stronger aspirin, like clopidogrel or ticagrelor? Or should I not add that antiplatelet agent? So now we're looking at antiplatelet agents, trying to figure out what's that cocktail that gives patients their best outcomes. So I'm going to move on from stroke if there are no questions there about stroke. And I'll move on to neuromuscular diseases. I mentioned Guillain-Barré to you a little bit, and that is basically this autoimmune demyelinating peripheral neuropathy that can occur acutely in patients as a complication of any infection. And like I said, we've seen it in COVID. It's not clear that it happens more often in COVID than any other disease. It occurred in 5 of 1,200 patients enrolled in Italy over that month. It usually occurs a week or two after the disease, sometimes much more, even like a month. And these are very sick patients who even can't breathe on their own because the nerves that supply the diaphragm can even become weak. Usually the treatment involves immunosuppressant, or is basically cleaning out the immune system with things like plasma exchange or IVIG, IV intravenous immunoglobulin. So it's something that we have to consider in the setting of a patient who develops progressive limb weakness. It's usually ascending leg weakness, limb weakness. So they start with like feeling like maybe their foot was dropping, and then they started to have trouble walking, and then they started to just like slowly feel do worse and worse. In the setting of COVID, it can be a little confusing because these patients can be short of breath. And so if you have a COVID patient who say their chest x-ray doesn't look like their lungs are damaged, it's something that, we have to think about is, could they have Guillain-Barré syndrome? There are other effects that COVID can have and have been seen in the neuromuscular system. There can be muscle injury. There can be a particular nerve injury, such as, facial palsies. And then you can have the nerves injured just from being critically ill. There's also been reports of the prone positioning causing people's arms to be stretched out such that they injure those nerves there in the brachial plexus. So that's another way that you can see a neurological manifestation of COVID indirectly. And then, my last slide is about the idea that rarely COVID actually can cause a meningitis or a meningoencephalitis. The difference between those two are the meningitis would be that COVID just infected the spinal fluid that bathes the brain, the meninge, and basically the meninges, versus an encephalitis, meaning that COVID actually entered the brain. So it could be viral, but it could also be autoimmune because the virus has created this immune response. It's not that common. We have seen it at UC because we basically get the toughest neurological cases in the region, and so rare things are a little more common in our practice. And then patients can sometimes develop something where it's an autoimmune disease where essentially the immune system is attacking the brain and causes something that looks almost like a single episode of multiple sclerosis, where the brain is sort of inflamed and there's demyelinating disease, sort of the same way that you'd see with peripheral nerves with Guillain-Barré. You can see that centrally in the brain as a one-time event, and the treatments are similar. It can be quite devastating. Again, rare. There have been increasing reports of it. I don't know what to make of that right now, of whether that's going to suggest that this is a little bit more common, relative to its rarity in the setting of COVID. I don't think we know that yet. And then there can be inflammatory syndromes in children. Patients can develop myoclonus. That's usually after they've been very sick, especially if they had low oxygenation. It can also be after an infection in general. It's uncommon, but basically it's sort of a startle reflex that you get with throughout the body. It's called generalized myoclonus. So people just have these positive movements. And then you've heard a ton about the prolonged residual symptoms that are likely multifactorial, that can include fatigue, dyspnea, in other words, shortness of breath. We talked about loss of smell and muscle aches. So, at this point, I think I do want to make a comment that, it's always tough as things are unfolding, for any disease, and it's been especially true for COVID, where we start to get information pouring in, and you have to figure out, sort of how much of this a 1 in a million phenomenon that we're all focusing in on, and how much of this is something that's going to become a trend that we're going to see once we get that full denominator of people with COVID, that we're going to see a ton of X, Y, or Z. So I put this cartoon up there just to make the point that what starts out as anecdote may eventually become evidence, but while it's anecdote, and so you sort of have to keep it in that context. And I have to say, I'm just going to editorialize for a minute and say I think there's just been a lot of lack of rigor in our press and our reporting about COVID that that has been tough to sift through for the general public. And so thankfully things are getting clearer and clearer as time goes on. And I'll just conclude then in summary that, my take-home messages are that the most common symptoms that you're going to hear about with COVID neurologically are going to be achiness, headaches, not thinking clearly, dizziness, particularly in the very sick patients. It's not just not thinking clearly, but it's actually being almost comatose, if not comatose. Um, and then obviously change of taste and change of smell are less common. And then uncommon, but real phenomenon are stroke, movement disorders, and other focal impairments. So thank you for your attention. I will mention as I'm closing that I did use, I don't know if any of you are familiar yet with UpToDate, but UpToDate.com is a really, I consider it one of the more rigorous sources out there for evidence-based updated medicine. And I did draw from that for this talk. So if there were areas that you particularly wanted to look at in depth, that'd be a good place for you to look at too. So that would sort of be the article that I would refer you to if you want to think about these things some more after this talk.
Great. Thank you so much, Dr. Khatri. It was a really informative and well laid out presentation of, I think, some of the neurological manifestations that are kind of swirling, like you said, in the public media and can be disconcerting. So very clarifying. Thank you so much. Class, so I'll open it up. Please ask your questions of Dr. Khatri, anything that comes to mind. I can start off the questions. So one thing that I've been interested in, and oh wow, a lot of questions are coming in. I'll ask the
Good.
students questions first, and then I'll ask my own at the end if we have time.
Okay.
So John was wondering, you mentioned how the olfactory bulb has lit up on brain scans when a patient has COVID-19. Have there been any
Mhm.
scans that indicate higher concentrations of those small punctures caused by COVID near the olfactory bulb, or are they just randomly throughout the brain?
Can you say that last part again? I didn't follow that.
Yeah. So essentially, he's wondering if the changes that are seen on imaging in the olfactory bulb
Mhm.
are these just unique to the olfactory bulb, or would you also see other areas of the brain abnormally on imaging due to the same type of neurological injury that's going on in the olfactory bulb?
Yeah, so like those white matter changes I talked about, you can see sort of reactions that way. So how much of that is, it seems less likely that that kind of thing is going to be invasion of virus, because if you saw that, you would see contrast and you would see breakdown in the blood-brain barrier. But rather it's sort of a reaction to this inflammatory state. So you can see things like that. And I guess kind of going along with that, you can see contrast enhancement to suggest sometimes, like I mentioned, the uncommon meningoencephalitides that can occur. So yes, you can see that in other areas, but clearly there's some sort of predisposition to the olfactory bulb, and we don't understand why. Um, you might have heard of this, heard about this, that, that is actually one of the early signs for Alzheimer's disease, where people will lose their sense of smell. So did they talk about that in your smell lecture? I'd be curious if you got any insights from that as well.
Yeah. So Dr. Setigot provided a nice overview of the kind of lost sense of smell, but I don't think he specifically touched on that aspect of it.
Hmm. Okay, yeah.
Um, So, kind of along those same lines, Arhama was wondering, it since, and again, this was in the podcast, there's seems to be maybe some link between COVID-19 and other illnesses like Alzheimer's. How would COVID-19 impact those who already have Alzheimer's or dementia? Are you seeing patients who have, or your practice, are patients presenting with dementia with worse symptoms, or is there any link between, patients who have pre-existing neurological diseases like Alzheimer's and the impact of COVID-19 on them?
That is such a great question. When people have things like Alzheimer's disease or Parkinson's disease, any sort of additional illness can just kind of throw them off balance and make them worse. So, I'm thinking of a particular patient that we had who came in and her Parkinson's was just a lot worse. And we do the usual things. We look for a urinary tract infection. We look to make sure she's taking her meds correctly. Well, in this case, she actually had COVID. And that was the exacerbating factor. And we treated her for COVID, and we basically, well, actually, we provided her supportive care is what we did. And she actually did pretty well, thankfully. For COVID wasn't too bad, but this is not uncommon. So this can happen, and it's sort of interesting because it's sort of like a lack of reserve, so that when you get this additional injury to your body, that's one of the first signs that you're not doing well. So we see this with stroke patients all the time. You have stroke patients who their stroke symptom was they were having trouble talking. Well, when they're really tired, even though they've largely recovered from their stroke, they'll have more trouble talking. And similarly, when they get another illness, one of the early things that they'll find is they have trouble talking. So some compensatory mechanisms fall apart.
So Justin was wondering, in the podcast that they listened to before, there was a mention of small leakages and punctures in the small vessels of the brain being seen in COVID-19 patients at autopsy, and he was wondering, could you explain how these punctures occur, and if this is known?
Yeah, so this comes down to this whole thromboinflammatory state. And as far as we can tell, what's happening is that there are, in this inflammatory cascade, basically factors are getting activated, like platelets and cytokines, and that's why we end up seeing these little areas of injury, like microbleeds, like I showed you, as well as those white matter hyperintensities I showed you that are signs of inflammation. So does that partly answer your question?
Yeah, I definitely think it does, and yeah, Justin said yes, so thank you.
Okay, good.
Charlotte had a question. So, she's again interested in this relationship between Alzheimer's disease and COVID-19. Are there growing evidence or any good research out there on why COVID-19 may increase the chances of developing Alzheimer's?
That is a $1 million question in our field, because we already knew before COVID-19 happened that when you develop any kind of injury to the brain, the same risk factors that are a risk factor for stroke, for example, are risk factors for Alzheimer's disease. There seems to be some sort of cascade that gets set off for, and we don't fully understand that. The NIH just funded a very large study that we're going to be a site in, that we're very excited about, called Discovery, where they're going to follow patients for 7 years after they had their stroke and just do everything to them, from genetic studies to detailed imaging to proteomics, and basically try to figure out what is it about this stroke event and how does it relate to the people who do versus don't develop Alzheimer's and other related dementias. So the bottom line is we don't really understand, and to the degree that we do, I can't say that there's any one answer. There's a lot of hand waving, but we know that there's a linkage that we need to understand better. We definitely know that if the better we take care of our general health, and particularly our vascular risk factors, the less likely we'll have dementia. And we know that COVID causes injury to that vascular system. And so we have to worry that COVID will contribute to more patients having dementia because they had another hit to their brain. What exactly those hits do that get you to this degenerative disease pathway is not completely understood.
So the next question is, are there any extra preventative measures that people who have pre-existing brain damage have to take if they get COVID-19, or even this, just to tack on my question, I guess, what's the long-term management of patients who have COVID-19 neurological illnesses? Do you guys have clinics for them, or what really is kind of the care that's going on for patients with neurological illnesses who get COVID-19?
Yeah, the process right now is very much similar to all of our patients that we see post-neurologically in terms of outpatient follow-up, and our emphasis is around, vascular risk factor control, exercise, physical therapy, occupational therapy, all of those things. Basically, it's the thought is that it's the same strategies that help us recover in general from any brain injury are the ones that we should use for COVID. But, someday will there be potentially, some, I think one of the things you wonder about is there some subset of patients who maybe look a certain way as an outpatient that we should think about, steroids, for example, a round of steroid treatments. We don't know anything about that kind of an approach at this point, and certainly want to do no harm until we know it's actually potentially beneficial.
So actually I was wondering, are there so a lot of the neurological pathologies that have been associated with COVID seem to be very severe. Are there any just like mild deficits? So of course you mentioned the brain fog, but any other mild neurological deficits associated with COVID-19 infection?
There have been reports of things like neuropathies where someone will get like a facial nerve palsy, sort of like a Bell's palsy. So that would be an example of a mild deficit. Yeah. And then the brain fog issue, when people, it's so hard to tease this all apart. What I'd love to see is a systematic study, which in fact, I know that that's been funded, is to look at patients who are these patients who are walking and talking and never got hospitalized and don't feel right, and be doing more extensive testing on them, including MRIs in a systematic way to understand if there are certain patterns that might help us. At this point, whatever is going on is, it's probably multifactorial.
And then I know this has been a lot of questions, but the students are just very interested. So last question, is there a higher prevalence of brain injuries due to COVID-19 among certain groups of people, whether it be along race, ethnicity, or social demographics?
Yeah, yeah. So, I think the easiest way to think about that is that you're more likely to have neurological manifestations if you have worse COVID. So anything that would make your COVID worse for you, which includes being African American, or Hispanic, or like, for example, the same hypertensive, diabetic, older, all of those things are going to put you at higher risk for more severe COVID. And when you're at more risk for more severe COVID, you're at more risk for neurological manifestations.
And then one more question just came in. So earlier in the semester, we had lecturers speak about a potential link between COVID and depression. Have you seen any of this in your patient population?
Yeah, definitely. And we see depression from all kinds of brain injuries, out of proportion to the depression you'd see from having a major medical illness. And the thought is there's something more going on there that, again, we don't have clear answers for, but I have a very low threshold for aggressively treating depressive symptoms in our patient populations, whether it's COVID or other neurological diseases.
Great. Well, again, Dr. Khatri, thank you so much. This has been a really tremendous lecture, and there's so much student interest in this topic. So this has been a great overview, and really excited to see where your research, sheds more light on how COVID-19 affects the brain.
Well, thank you. And I have to say, as you saw, there are more questions than answers. I don't think anyone is an expert at this point. And so hopefully I got your wheels turning, and appreciate you all listening so patiently and asking great questions.
Great. Thank you.
So take care. Bye, everybody.
Bye.